Hi, welcome to Tea Time in Olympia. I'm Lucas Miller.
And I'm Amy Layton.
Thursday, December 1st was World AIDS Day, so today we're going to talk a little bit about HIV and AIDS and the transgender community, the relationships between them, and some of the challenges that transgender people face when seeking services to find out their HIV status or to seek treatment or prevention strategies for HIV and AIDS. A little later, we're going to talk about the informed consent protocol for trans people seeking transition services. We're going to talk a little bit about the real life test and its origins. So that'll be a little later on, but we're going to start out with HIV and AIDS.
So let's jump on in.
Yeah.
I'm going to come from the aspect of I don't know anything about anything, as I should as an interviewer. So let's start at the beginning of the list of questions here. How many people are now living with HIV or AIDS?
Well, worldwide, we've got some 35 million people living with HIV and AIDS. We know that 1 out of 4 of new HIV infections are in people between the ages of 13 and 25.
Oh.
The other 3/4 are mostly men ages 25 to 45. And of those, the largest affected population are men of color who have sex with men, most especially Black and Latino men who are sexually active with other men. The interesting thing about that figure is that until very, very recently, trans women were kind of lumped in with those figures counting men who have sex with men, because for a variety of reasons, the people doing the research have not really understood the difference between a trans woman and a gay or bisexual man. Mm-hmm. The research tends to be done along the lines of people's assigned sex at birth, which of course is a problem because the needs and the risk factors and of course, everything that goes into making a given population more vulnerable to HIV are very different for the transgender community than they are for the cisgender gay and bisexual male community.
Oh yeah. You don't have to tell me.
Yeah.
Well, though I'm coming from the aspect of someone who doesn't know, so
Right.
I guess you do have to tell me.
Yes.
Yeah. I've had my own experiences where I've been kind of denied being allowed to donate blood because I'm trans, and I would not accept them calling me a gay male.
Well, exactly, and your risk factors are not the same as those for a gay or bisexual man. And consequently, that has implications for the safety of our blood supply. The fact that, they're trying to base the safety of our nation's blood supply on the identities of certain populations, and not so much on behavioral factors, which is what they really should be doing. Consequently, we know very little about, who is a risk to our blood supply, who is trying to donate, what their actual risk factors may be.
Because it's always a variable. You never know, what could be normal behavior, normal activities for a cis person might be normal activities for a trans person, or vice versa. And it's never good to just politicize people's lives like that.
Well, precisely. I mean, the assumption that a trans woman is the same as a man having sex with other men is very faulty because, of course, many trans women are not sexually active or are not sexually active with men. There's, to lump them all into the same risk category really, leaves out an entire key population, that is at elevated risk and more in need of services and more in need of having, accurate long-range research being done on the actual risk factors.
It feels like, to me, personally, in my own opinion, it feels like that by lumping trans women or trans men into categories that they are not, that it's just reinforcing the stereotype that trans women are not men. And it keeps reinforcing the stereotype that trans women are men.
Right.
When that just isn't true.
Yes.
Science has proven that now. I don't know if I'm pretty sure it's definitively proven that trans women are not men, biologically speaking.
Well, when you're doing medical research, you're not always necessarily focusing on social factors, political factors, identity factors. If you're very narrowly focused on the medical science, what you're mostly interested in is, for example, is semen being transmitted from one partner to another? What are the actual routes of transmission? What are the actual, how is that transmission being accomplished, and what does that mean for which populations are showing the highest, rates of new infection? It's only recently, 2 years ago in 2014, the World Health Organization released a new policy brief concerning transgender people specifically, and HIV and AIDS research, treatment, and delivery of services. And it was a brief outlining some better practices concerning how research should be designed, how key populations should be identified, and how these populations should be centered for the purposes of delivering better services and doing more accurate research. So, one thing we know, for example, is that trans women are at particularly high risk. I believe the going figure is they're something like 49 times more likely to become HIV positive than non-trans women. And trans women of color in particular, when your risk factor compounds and magnifies when you have different identities intersecting. So, trans women in general, 49 times more likely. Trans women of color, 56% more likely, or 56 times more likely. Add into that, if they are perhaps engaged in sex work, or there are other factors, sort of steering them towards high-risk behaviors. There are so many intersecting realities for trans people, all of which come together and magnify to make us much more vulnerable to HIV infection, or to, if we are already infected, to get in the way of our seeking proper treatment.
So that kind of leads me back to the question. I mean, do we have a definitive?
Before we get to the next question, Luke, you keep looking towards cameras 1 and 2, and it looks like you're kind of looking off stage at somebody, but not into the camera.
Oh, okay, sorry.
So just remember to talk to people.
Okay.
Go ahead.
So that kind of leads us back to the question, is there a definitive answer of how many people are now living with HIV?
Well, like I said, that 35 million people worldwide in general, just of all populations. I don't know precisely the precise number of trans people that are currently living with HIV and AIDS, because actually just the data simply hasn't been collected in the way that it should. So, the numbers that we have for men who have sex with men, trans women have been lumped into that, are kind of included in that figure. It's only recently that trans people are being studied as a separate key population. So hopefully very soon we'll get some reliable data about exactly how many trans women, how many trans men, how many of those are people of color. We'll start to have some more specific numbers, so that we can know why the risks are so high for certain populations, what are the barriers to getting those populations better access to the services.
So, I mean, trans people are at a pretty high risk, but what other communities are at high risk of HIV/AIDS?
Well, again, people of color, sex workers, anyone who's engaging in high-risk behavior. Again, 3 out of 4 new infections are Black and Latino men who are sexually active with men. So that does seem to be the highest, population at risk. And again, it's because the research has not been designed to take into account separate populations, our data on that is really not very good. And that's something that has to change. And that was part of the World Health Organization's recommendations for better practices, is to start designing research that looks at, trans women as a specific population, trans women of color, trans women of color who are engaged in sex work, taking into account all these different factors. They also had a lot to say about why trans women, trans people, may be forced toward high-risk behaviors by the structural and institutional violence, including the violence of poverty and discrimination that trans people have to deal with, every day, as a matter of course, and how these are magnified in communities of color.
Well, while we're on the subject of HIV and AIDS, and I know there's lots of resources out there, what local resources exist for people living with HIV/AIDS, like in the area, or who do you want to, or who want to get tested or learn more about the risk factors, or where do they go?
Well, here in Olympia, we have an office of the Pierce County AIDS Foundation, which is right over on 4th Avenue, and they offer free confidential testing. And they do that every Friday from 2 p.m. to 7 p.m. at their offices. You can call the number at the bottom of our screen, 360-352-2375, to schedule an appointment. We also have an organization in town, Empowerment Washington, which handles the prevention and education side of things.
Okay.
PCAF does a lot, of testing and education around things like PrEP and PEP, which are a new medication that may help prevent new infections. And I'll say a little bit more about that in a minute. What Empowerment does is we hold safer sex workshops, healthy relationship workshops. We do a lot of community building, especially among gay and bisexual men, but lately we've tried to really open that out to all kinds of communities, including trans people. We distribute condoms. We educate people about some of the other tools that people have to manage their HIV status, including abstinence, new medications, barrier methods like condoms or dental dams. All of the ways that people can, if they are negative, remain negative.
And also enjoy their safe sex and
Yes.
fun at the
Yes.
same time,
Right.
while being protected. 'Cause
Exactly, yes.
It's not like it's the worst thing in the world, but it is something that is serious, and it's important to be as protected and up on it as you can, so you can best protect yourself, as well as be safe, as well as have fun.
Yeah. Well, of course, I was a young teenager in the early years of the AIDS epidemic, back when it was pretty much universally considered a death sentence if you became HIV positive or started to develop symptoms of AIDS. Obviously, some things have changed, in 30 odd years.
Thanks, medical science.
Well, medical science, is making some progress. We have better medications now that are helping people live longer, healthier lives who have HIV. We now have PrEP and PEP, which are basically a drug whose trade name is Truvada. I'm not sure exactly what the chemical name of it is, but recent studies have shown that regular daily doses of Truvada, in combination with condom use, can actually help a person remain HIV negative. It can prevent someone from seroconverting. It's not. I don't think it's a panacea, but it does seem to be one more in that arsenal of weapons that we have now to combat HIV and AIDS, and to hopefully lower the number of new cases that we'll see. But of course, a lot of education has to be done around it. So we do hold workshops teaching people about PrEP and how it's used, and getting people to understand that it doesn't work unless you take it every day regularly. all
Yeah.
that kind of stuff.
Can't just take it
So-
once a lifetime and have a
Right, exactly. It
instant
doesn't work
effect
if
that
you don't
works for
take
your
it.
life.
Yeah, yeah.
So we've kind of touched base on why trans people are at high risks, or why the community, what communities are at high risk, and some resources. Did we really?
Well, we can go
touch
back a
base
little
on-
bit, I think, to
yeah.
why trans people are at such high risk. And thankfully, this is something that it seems the World Health Organization and other, large organizations dealing with the problem of HIV and AIDS are finally starting to recognize that there are so many interlocking forms of institutional violence that drive trans people toward high-risk behavior. One of them, of course, is discrimination, poverty, the need to make a living doing, high-risk things, the lack of protection from discrimination, driving people into, sex work and other
High risk behavior.
ways of making a living that do not have any kind of protection around them, that are actually criminalized in many places. There are still something like 79 countries in which same-sex sexual activity is criminalized.
Oh wow, there's still that many.
Yeah, yeah.
Oh wow.
Thankfully, the United States is no longer one of them since 2003. Let's hope that remains the case.
I certainly hope so.
Yeah, but and then of course there's all of the factors of violence and poverty that affect communities of color. So when you bring those two identities together, and then the violence that affects women, then you've got a lot of intersecting identities there that are targeted. Also, it may be that people who are looking to their sexual partners for affirmation of their gender identity may be more likely to consent to unprotected sex in order to get that affirmation. There's the fact that trans people who are perhaps on hormone therapy may prioritize their hormone therapy over HIV testing and treatment.
It's a very real risk. I mean,
There's
with today's
certainly the
insurance
fact,
companies and
yeah,
how
yeah.
living is going, or it's hard to even make a living. I mean, I can understand why
Yeah,
people
yeah.
would prioritize that.
Yeah. There's the fact that trans people have historically not had very good experiences with the healthcare profession. If you routinely dread going to the doctor because you feel that you're going to be misgendered or treated disrespectfully, or even in some cases people have been denied care, because they are transgender, you're going to be less likely to go and get tested. You're going to be less likely to go and ask about PrEP and PEP. You're going to be less likely to seek the kinds of services that are relevant to you as a person, who either is HIV positive or may become so. So there are so many specific factors that make trans people more vulnerable, and I think it's very hopeful that organizations like the World Health Organization are finally starting to recognize this.
Oh, yeah.
And part of their recommendations for best practices are making the trans community and the organizations within the trans community, vital partners in exploring that relationship and designing research that will be beneficial, to the trans community in helping us, helping trans people to manage their HIV status or to seek treatment when necessary.
Rather than just not.
Yeah,
I mean,
yeah.
I'd
rather
rather
than
somebody was able. I think that it should be free testing, like everywhere. Like they shouldn't have to. I don't know if it is or.
Well,
you know what I mean?
there is free testing available in a lot of places. Again, Pierce County AIDS Foundation's testing is free. It is confidential. You just schedule an appointment. It doesn't cost anything. Some insurance plans cover
Okay.
HIV testing.
Okay.
I believe there was a time at which Planned Parenthood, I think Planned Parenthood still offers HIV testing. I don't know if it's free anymore. But
Not after the last few
yeah.
years they've had.
well, yeah, and unfortunately, we're looking probably at a time when, we have a vice president who wants to defund HIV and AIDS
Testing.
services and research. But the thing is, HIV and AIDS is a global issue. So even if we see some rollback here in the United States, I'm holding out hope that the rest of the world will continue, and that.
We may get snuffed out, but it's up to you, rest of the world. This one we need your help on.
Yeah. But because trans people have been made so invisible in the research, that has kind of left us kind of out in the cold, if you will, with regard to seeking services, getting treatment,
Getting everything you need.
managing our status. Yeah.
All right. Well, should we move on to informed consent, or because we kind of covered the other questions, like
Well,
some of the
let's-
barriers and.
Let's see. Well, so I can also tell you that here in Washington, we're looking at well over 500 new cases of HIV every year. There has been a slight decrease over the last decade. We don't know, if that trend is going to continue, or
Probably when
what
sex
new
ed
research
started
design
using
is.
condoms to, sorry.
Well, of course, in the late 80s to early 90s, when organizations like ACT UP were, very active, many cities were doing huge, safer sex campaigns, really pushing condom use, which at the time seemed to be the only or the best strategy for managing HIV status. Now we have a few other options. I think that created kind of a generation of gay and bisexual men, but everybody really, who for whom AIDS was a very present daily reality. And the fact that at that time so many people were dying from it, because we didn't have these new drug therapies then. But that generation is now aging, and a new generation of younger gay and bisexual men have come in kind of after that,
Like me as a trans
after that
woman.
big flood of kind of what I guess you could call AIDS culture sort of passed on, and then this new generation did not have all of that. They did not have the safer sex campaigns. They didn't have ACT UP. They didn't have a lot of the organizations and the public visibility. So that new generation didn't get the education that they needed, and that's we started to see a rise after seeing quite a fall in new cases among gay men. Then it started to rise again.
I know when I went through sex ed, they didn't really talk about HIV or AIDS or anything like that. It was just one of those things that you better not be gay and you better not get it because you'll die.
Yeah.
So I don't know. I was always, I always lived in a family where it's like you be safe. They didn't tell me as a young kid like you be safe, but when I hit that age in life, they're like you be safe. I'm not saying you can't do this. I'm not saying don't do this. I'm just saying be safe.
Yeah.
Wear a condom. Do what you have to do. Because I mean, it's to my family members at the time, it was still like the death sentence. You know what I mean?
Yeah.
Which at that time there was still, there was something out there you could do, but to help. But yeah, it's not a death sentence anymore necessarily. It's
Not necessarily, but it's still a problem.
It's still pretty serious.
It's still a global epidemic. And if we don't, remain vigilant, keep doing the research, and keep educating people on, how to manage their HIV status, it could easily become
Oh yeah.
that, you know,
Yeah,
that
it's
reach
like,
those epidemic proportions again. I mean, as it is, that first, 10, 15 years of the epidemic, spawned, an entire history of gay culture, in which you could not even talk about being gay without talking about AIDS. A whole generation of artists and writers and thinkers and some of our best and brightest, died and left behind, this body of art and literature and film and just all kinds of culture. The history of the early days of that epidemic and how the community responded.
which was mostly fear. It was
There
fear
was a
of the
lot of
unknown.
fear, but there
that,
was also
you
a
know,
lot of hope and a lot of resilience.
True.
I guess I'm a little bit biased because as an artist myself, I tend to look at history through the eyes of an artist. So I kind of, fix onto that, the literature and the art and the
culture.
what was left behind by that vanished generation.
And I got to say, it did feel kind of like there was a gap in creativity there for a little bit when I was growing up. So that was probably the after effects of
Yeah.
of what.
But
we were
now
missing.
we have a new generation of people who have been living with HIV and AIDS for
Their entire
a long
lives.
time. Because we have new methods of treatment that are helping people live longer. We kind of still have that thread in our culture, but the story has changed, and I think will continue to change.
I just, I hope one day that it can be eradicated. Just no more AIDS.
Well, I think they may be making some progress toward that. There's a lot of activists and a lot of researchers and a lot of people just, dedicated to, ending HIV and AIDS once and for all.
I say we put it up on the web in a game form and have all the gamers fix AIDS within a couple weeks. They've already done it with something else. I can't remember exactly what it was, but scientists put up a scientific question in the form of a game because they couldn't figure it out after 10 or 15 years of trying to figure it out. And within a week, gamers had figured it out. Within a week, they had an answer to their problem that had plagued them for 20 years.
Maybe.
I think that's what we need to do with AIDS, and it could work.
That's one
Come
strategy.
on, world! Come on, gamers! You can do it.
Yeah, but to get back to the place of trans people in all of this, one of the reasons why we aren't seeing trans people coming for services is because they really haven't been centered in the research. We don't, for example, have a lot of data on how drugs like Truvada and other antiviral or antiretroviral medications react with hormone therapy, for example. We don't know how, for example, a surgically constructed neovagina might be more or less likely
to receive it.
Right.
Yeah.
We don't really, we know a little bit about how, a cis woman's vagina reacts to, say, taking PrEP. But we don't really know how a trans woman's body, if it has been surgically modified, how that changes.
Okay.
We don't know, we don't really know how, trans bodies, safer sex education, like condom use, has mostly been designed for cisgender bodies. There's not a lot of education specifically directed at, trans people on how to have safer sex, how to use condoms, how to use dental dams, how PrEP or PEP might, affect a trans person. There's not a lot of data on how trans people's sexual behavior patterns might be different from those of cisgender people, and how that affects, a person's likelihood of seroconverting or not. So really, the bottom line here is just that we need better research, and we need research designed around transgender people as a specific key population. That is not only takes into account how we are different from other populations that might be at risk, but is also, respectful of our identities, that makes us want to be part of the research, that makes us want to, get tested, seek treatment. It's long been understood, for example, that when people's stress levels are reduced, they take better care of themselves. I did read about one small study involving transgender women that showed that when their stress, the stress they had resulting from discrimination, violence, all those external factors was reduced, those that were on an antiviral or an antiretroviral medication were more likely to take their medication regularly, take it properly, and to take care of themselves.
Oh, okay.
So, clearly, reducing discrimination, reducing violence, reducing all of the other stressors that, impact on transgender people's lives is going to have a direct effect on, how we manage our HIV status, how we take care of ourselves if we are HIV positive, how we interact with service providers, how we seek services. Obviously, this is going to take a lot of training, very focused training of healthcare providers, all over the world in all areas of HIV and AIDS service delivery. And it's going to take some time, and it's going to look different in every country because, again, many countries not only criminalize same-sex behavior, they may also have very restrictive social or legal policies about, cross-dressing, for example, or what they see as cross-dressing. Some countries, still have really draconian laws, that impact on gender non-conforming people, and that, that occurs not only in the social sphere and the legal sphere, but in the medical sphere as well.
Well, I feel like I've learned a bunch of new things today because clearly I have learned some new things. You got to see it live or on the tape.
Well, we at Empowerment are definitely wanting to see more transgender people show up to our workshops, get involved, become volunteers. We have, we're looking for board members. We're looking for, volunteers at all levels. We really need people to get involved, to help us learn what we don't know. To help us design safer sex workshops and other kinds of trainings that take trans experience into account, that make sure that this is not an invisible population anymore. Because, of course, it's a truism that when you don't center the marginalized population, you automatically marginalize it, right? So, we need to start really concentrating on why trans people are at risk, and how we can deliver services better. We're going to talk a little bit now about informed consent and whether we should move from the WPATH standards of care as they currently exist to an informed consent protocol for people who are seeking transition care, such as hormone replacement therapy, SRS, top surgery, and other medical interventions for gender reassignment.
Gender confirmation, as it's known now.
Gender confirmation, gender affirmation, genital reconstruction surgery is what I prefer to call it because it just says what it is.
Ooh, sorry.
Gesundheit.
Sorry.
The standards of care, as set forth by the World Professional Association for Transgender Health,
WPATH for short, as
right?
it's known.
Which used to be the Harry Benjamin
Society.
International Gender Dysphoria Association. I always stumble over that acronym because it's so long
It's
and
a long
ponderous,
one.
and it doesn't spell out anything. Anyway, so what was originally the Harry Benjamin Association changed a few years ago to the World Professional Association for Transgender Health. The standards of care are basically a list of protocols, not rules or laws, just recommendations for medical service providers such as therapists, social workers, endocrinologists, surgeons, general practitioners, doctors who treat transgender people, both just for general health care and for transition-related care. It's basically, it amounts to a set of what they feel are best practices, and they were established for two reasons. One was to protect, these medical providers from the potential of lawsuits. Back in the days when, some of these therapies were considered experimental, when, transsexualism and transgender were not really well understood by the medical community. There was a lot of potential, when the surgeries were not so good and they didn't really know as much about HRT, there was a lot of potential for malpractice suits against the practitioners who served transgender people. That's not so true anymore, but still, a lot of practitioners like to have that added layer of legal protection. The other reason that the standards of care were established was, of course, to protect trans people from unscrupulous practitioners who might take advantage of, someone's desperation to start hormones or get surgery, and not take care of them as well as they should. So the standards of care were first established in 1979, and they originally called for 3 to 6 months of therapy, where you would have to talk to a therapist and get diagnosed with what was then gender identity disorder, as listed in the Diagnostic and Statistical Manual of the American Psychological Association.
The newest one doesn't list it as that.
The most recent version of the DSM, the DSM-5, the name of the condition has been changed to gender dysphoria.
Okay.
And I believe it's in a different section of the manual. It's not, the criteria for diagnosis are not quite as pathologizing. It's not characterized as a disorder anymore. It provides for someone who is experiencing real distress over over a disconnect between their assigned sex at birth and their inner sense of gender identity. So in order to access services like hormone replacement therapy or chest reconstruction surgery or genital reconstruction surgery, you would have to spend a certain amount of time seeing a therapist who was qualified to make a diagnosis, and then that therapist would write however many letters of recommendation, or you might have to go to a couple of different therapists to get, a certain number of letters, depending on whether you wanted hormones or surgery or what kind of surgery. And you would take those letters to a doctor who could then prescribe the hormones or perform the surgery. But either way, you had to pass through this period of mental health evaluation and get that diagnosis through the DSM in order to get access to those, to what you really want, which is the hormones and the surgery.
I know when I started transition, my doctor wouldn't prescribe hormones unless I had a note from my therapist stating that I was, in my sound mind and knew what I was getting into and had discussed it. And it's not that she required it. It would. She said that it helped her feel a little better, knowing that I'm not just coming in saying I want this, give it to me now, kind of thing. but she also had me sign papers of informed consent at that point.
Yeah.
You know, now, that she had realized, learned that it wasn't just me saying I'd like to do this, it was me saying I need to do this.
Right. Right. Now, so that sounds a little bit closer to what some people are recommending as an informed consent protocol. There may still be a role for the mental health practitioner, but what would change is that you wouldn't necessarily be required to have that mental health practitioner diagnose you, or you wouldn't necessarily need a letter to take with you to an endocrinologist.
Okay.
Now, one of the other reasons why the diagnosis was listed in the DSM was because the DSM also, in addition to diagnostic criteria for various conditions, also lists the insurance codes by which you're supposed to be able to get treatment for certain conditions covered.
Okay.
Now, that never had very much meaning for conditions like gender identity disorder, because very few insurance companies, like I think only maybe one or two in the entire country used to be, would offer any coverage for transition care. In fact, there was a time when, an insurance company could drop you from their regular coverage if they found out you were transgender.
Yeah.
So basically this placed, or this places, a burden on the trans person, first of all, to prove that their gender identity is what they say it is.
Because we don't know ourselves well enough, we
Exactly,
have to have
yeah.
someone else write it out for us.
Well,
Sorry.
Unfortunately, this is the way that the medical system works. In a capitalist economy like ours, it's a very controlling, very paternalistic kind of relationship between, the medical system and the patient.
I always found it very odd that a cisgender woman could walk in and ask for hormones,
Yeah.
and they would give her hormones without the drop of a hat. But when I asked
Right.
for hormones, it was, well, we need a doctor's note.
Yeah.
Before my doc, we need a therapist note before we can prescribe you hormones. But
Yeah.
my friend who went the next day got hormones, and she's cis. You know what I mean?
Yeah.
It was
Right.
really,
Yeah.
like, why do I need? I've clearly come to this decision. Sorry, I'm ranting now.
No, well, I mean, again, it's a double standard that trans people are held to, because of course, people are allowed to make all sorts of catastrophically life-changing medical decisions according to the informed consent protocol, without having to go through months of therapy, without having to be signed off on by a mental health practitioner.
Imagine if everyone with cancer had to have a mental health screening before they got the cancer drugs they needed to kill the cancer or make it better.
Precisely.
It's shocking. It's
Yeah.
shocking. If that were to happen, there would be outrage across the world.
Oh, yeah.
Outrage
Yeah.
across the world.
Yeah.
But
Yeah, I mean, nobody is required to go through 6 months of therapy before they have a baby, for example.
There are plenty of people who should be going through
Or,
therapy before
or
they
terminate
have a
a
baby.
pregnancy,
Yeah. Yeah. Well, some places they make you have a funeral for it.
Well, we'll soon put a stop to
That's a
that.
different subject for a different day.
That's a whole other rant. So early on, the standards of care required you to get one letter from a mental health practitioner in order to access hormones, and 2 letters to get genital reconstruction surgery. To get top surgery, that is bilateral mastectomy for a transmasculine person, it seems to have varied. It seems to have depended upon the mental health practitioner and the surgeon. And even now, a lot depends on the doctor, the endocrinologist prescribing the hormones, or the surgeon performing the surgery, what they require as far as how many letters they want you to get and from what level of mental health practitioner. And that seems to have a lot to do, as I said, with protecting themselves professionally and financially from malpractice suits.
Yeah, there was a lot.
Yeah, which is understandable, But if we were to move to an informed consent protocol, this would give the patient much more autonomy. It would be much more respectful of the individual's right to self-determination. And it would be much more respectful of the individual's lived experience of their own gender identity. And this is one of the big reasons why trans people have objected to, or I'll even say resented, this requirement of having to go through therapy and be diagnosed according to the DSM. Because having to get, a professional, and usually in the old days, a cisgender professional with no personal experience of being trans,
or LGBT for that matter in most cases.
Yeah. To legitimize your experience is really very patronizing. I mean, it's quite understandable why some people, really want to do away with that. Not to mention the added financial burden, because in
hundreds of dollars saved by not having to see a therapist to be able to get your hormones, even though you're trans and they know you're trans.
Having to see a therapist, once a week or once a month for
6 months,
6 months to a year, and none of it covered.
Oh, yeah.
That's a pretty significant outlay of cash that you could be putting toward your hormones, which used to be also weren't covered, or surgery, which is always very expensive.
See, I had issues with hormones myself being covered by the Medicaid program here in Washington.
Oh, yeah?
Back before I had my gender marker changed to correctly show my my gender identity.
Yeah.
They wouldn't cover my hormones because I was listed as male in their computers.
Interesting.
And it was only when I got that fixed to female that they started to pay for them.
Yeah.
But that was, at the time I was on a lower dose, so it was only $12 a month for me.
Yeah,
so I was able to afford it at that time.
Yeah.
But the Spiro, I had to go a couple months without the Spiro and naltrexone.
Yeah.
Or I think I'm saying that right. I haven't had to use it for several years, but
Yeah.
So I had to go without Spiro for a couple months while that was all figured out and straightened out.
Right.
And so I'm just saying that if you don't think that can happen still these days, it can still happen.
Yeah, it's really interesting how many conflicting stories I hear about people's experience with Washington State Medicaid, which in theory does cover, all transition-related services.
See, they cover my laser hair removal, and they only cover from the chin up. So it doesn't cover the beard area, so I have to still
really
shave down there.
Yeah.
Which is really bizarre to me. It's like if you're going to cover something, you should cover it, not cover half of it.
Yeah.
And then just leave the person hanging.
Well, it used to be that electrolysis wasn't even considered a medical procedure.
Oh yeah.
So
which it
wouldn't
totally
even
is.
wouldn't have even come into the purview of the insurance companies.
Yeah. So I'm glad they're even covering it. It's
yeah,
just it's frustrating to know that I still have to go and pay for the bottom half myself.
Right.
When on Social Security I don't get a lot of money anyway.
Yeah. See, and I had a different experience getting my hormones covered because for one thing, testosterone is quite a bit cheaper than the estrogens that are required for male to female. And when I first got on Washington Apple Health a couple of years ago, after the Affordable Care Act kicked in,
Gonna miss that.
there was no problem. I was covered 100%. Had no issues with it. And I don't know if that's because testosterone is just an easier hormone to monitor and administer, and a much cheaper one. I've always said men are cheap and easy. But, I hear a lot of conflicting stories. And then, of course, from people who, for example, are trying to get their hormones covered through the Veterans Administration. That's just a bureaucratic nightmare.
Oh, yeah.
There seems to be a lot of there's very little consistency across the board with people's experiences of trying to get this care covered. But anyway, back to the standards of care. So we are now on version 7 of the standards of care under WPATH. Now, version 7 recognizes informed consent as a possibility. However, the standards of care has always been a lot more conservative, I guess you could say, from the time that the Harry Benjamin Association formed and the standards of care were written. More conservative even than most of the doctors who were working in the field of transgender health. Early folks like Benjamin himself, Dr. Richard Green, Dr. Leah Schaefer, a few other early pioneers in the field, who were not quite so stringent about, for example, asking people to complete that real life, what they call the real life test, before being prescribed hormones or allowed to get surgery. So version 7 is getting closer to informed consent, but we're not quite there yet. They still require the letters and the diagnosis.
Well, at least we're not considered to have a mental disorder now.
Yeah,
Rather,
that's
that was very insulting. It's like,
yeah.
I don't have a disorder,
Right.
but I know it
Yeah.
has to be like that to be in the system. And
oh yeah, yeah.
So it's,
Well, the pathologization of our identities, has also been a big contributor to the stigma that we face when trying to move through society.
oh yeah.
And I think it's probably also a big contributor to some of the systemic violence that we experience also. So, reducing that pathologization, I think is a very, very good thing. So anyway, what would be good about moving from the current standards of care as they're structured now to an informed consent protocol? Well, as we said, it would be less paternalistic, less controlling, more respectful of the individual's experience. It would probably end up being a lot cheaper for most people.
Just a second. Edit that out. Sorry.
But on the other hand, what would be some of the drawbacks of that situation?
Well, it could mean that someone who's not informed properly can jump to conclusions without really having to sit down and think about all the different options and what's available and why they would believe or think this way in order. I don't know. I'm not saying that right, but I mean.
Part of the assumption underlying the informed consent protocol is right there in that first word, informed. The idea is that you would talk directly to your endocrinologist or your surgeon, and they would inform you of the potential risks, the likely outcome, alternatives that you might explore. They would make sure that you had that information.
And what does and doesn't happen with hormones. I remember my doctor made me sign a whole string, a whole string of statements like, you won't do this, you can't expect this to happen, hair growth in the head is not going to happen, all the basic stuff that as someone who's studied it for many years, you know what I mean? Someone who is clearly informed, stuff that I would see as second nature, like, oh yeah, of course that's not going to happen. Oh yeah, but I can see why they had so many, because I can see so many people not doing that research and just walking in. I mean, one thing that I get a lot from cis people who don't necessarily understand is that they think that you can just walk in and get hormones one day and then have a surgery the next day and walk out next week a whole different person, when this is a many year-long process. It's not, I mean, I myself have been in the transition for over 2.5 years, and I'm still working towards being able to get my surgery at some point down there. And yeah, just this whole climate in the country right now is really affected
I hear you.
me and a lot of people
I've
like
been
me
in transition for 10 years,
Yes.
working towards getting my surgery. And I've been on testosterone for that long.
And we still have to have 2 doctor's notes after all this time saying that our identities are what we say they are, and that we are of sound mind to even have this done. When someone who has to have a life-saving, you don't do that to veterans who get stuff blown off them in Iraq.
Right.
They just, that's informed consent right there. Okay, you're good to go.
Yeah. Yeah.
I mean, I hate to use that grim or use that comparison, but it's just that's the easiest one I can think of at the moment, to be honest.
Yeah. Well, 10 years ago when I started, when I first went to see a therapist to get that diagnosis and get access to hormones, I saw one person for about 6 months, and she was willing to refer me to the endocrinologist that she used. So I only needed the one letter to access hormones. And I was able to use more or less the same letter to get top surgery. Now, what'll happen when the time comes, to get bottom surgery, I'm not sure. Hopefully it won't involve too much rigmarole, but,
We can always hope, but
fingers crossed again.
as much as things are getting easier, they're also starting to look a little harder and a little more grim in today's climate.
Right. Well, but again, a lot depends on the individual surgeon.
That is also true.
Some endocrinologists are actually starting to move on their own to an informed consent protocol to say, I don't require a letter. You just come to me and we'll talk and we'll, I'll make sure you know what you need to know, what you can and can't expect, all the potential side effects, because the fact is, even after many, many years of use of hormone therapy, we don't really know all of the potential side effects that estrogens or testosterones can have. But anyway, so to move on, another requirement of the SOC is the real-life test. Nobody seems to know exactly how the real-life test became part of the standards of care. Aaron DeVore, trans historian, thinks that it may have originated in a pamphlet that was put out by the Erickson Educational Foundation. Reed Erickson was a wealthy and somewhat eccentric trans man who funded a lot of the early gender identity clinics. His doctor may have been the one who came up with the idea of spending 6 months to a year living in your target gender before you could access the medical services.
It was kind of, I viewed it growing up when I read about this. I viewed it as a way of them trying to say, well, you have to prove to us that you are who you say you are. So we have to see that before we'll take you seriously.
But there's actually references to a trial period in some of the earlier literature.
Okay.
So, it may have originated before that. But, there's a lot of reasons why this could be impractical or even dangerous for someone who has not been through the physical transformation, the changes, to try to live in the world, as their target gender. And also, there is no empirical evidence to suggest that a real-life test of any duration improves the outcome or, makes it less likely that the person might regret their decision. So, it's one of many aspects of the standards of care and the way that WPATH has kind of steered people into transition or through transition that is a matter of debate in the community. And it's something that I think will continue to be a matter of debate. And I believe that we are seeing, an organizational transition. People are going to start moving toward that informed consent protocol. Because, of course, these treatments have been in use for so long, it's really ridiculous to call them experimental anymore. They're proven to work. And I think it's time that, people were able to exercise their right of self-determination and access them on their own.
Well, it looks like we have reached the end of today's episode.
So we'd like to thank you for joining us on Tea Time in Olympia, and we'll see you next time.
See you next time.
Yep.